Septic shock is a life-threatening condition where infection leads to severe circulatory failure and tissue hypoperfusion. It is a medical emergency requiring rapid, coordinated ICU management, with early recognition being the first and most important step. Suspect sepsis or septic shock in patients with fever, low blood pressure, altered sensorium, and raised lactate levels. The goal is to restore tissue perfusion, control infection, and support organ function. For initial assessment, immediately place the patient on monitors to record heart rate, blood pressure, oxygen saturation, and urine output. Secure 2 large intravenous lines or a central line and provide oxygen. Prepare for airway protection and mechanical ventilation if needed. Begin rapid infusion of crystalloids like normal saline or ringer lactate at 30 milliliters per kilogram within the first 3 hours. For an average adult, about 2 liters of fluid is given quickly while monitoring blood pressure, urine output, and capillary refill. Continue fluids if mean arterial pressure improves and urine output rises above half a milliliter per kilogram per hour. If blood pressure remains low after adequate fluids, start vasopressor therapy. Norepinephrine is the first choice drug. It is started at 0.05 micrograms per kilogram per minute and titrated to maintain mean arterial pressure above 65 millimeters of mercury. If the target is not reached, vasopressin at 0.03 unit per minute or epinephrine may be added. Before giving antibiotics, send blood and other relevant cultures. Administer broad-spectrum intravenous antibiotics within the first hour. Common choices include piperacillin, tazobactam, meropenem, or ceftriaxone combined with vancomycin. Modify treatment once culture results are available. Identify and remove the focus of infection as early as possible for source control. This includes drainage of abscesses, removal of infected lines, or surgical debridement if required. If there is poor heart function or low cardiac output despite fluids and vasopressors, start dobutamine at 2 to 20 micrograms per kilogram per minute. In refractory shock, hydrocortisone 200 milligrams per day may be added to help maintain blood pressure. Monitor blood pressure, urine output, and lactate levels closely. Insert an arterial line or central venous line if available. Maintain urine output above half a milliliter per kilogram per hour. Provide ventilatory support if the patient develops respiratory failure. Start renal replacement therapy if there is severe kidney injury or rising creatinine with fluid overload. Maintain blood glucose between 140 and 180 milligrams per deciliter using insulin infusion. Provide low molecular weight heparin for thrombosis prevention and proton pump inhibitors, such as pantoprazole for stress ulcer prophylaxis. Begin enteral nutrition as early as possible. Reassess mean arterial pressure, urine output, and lactate every few hours. Adjust fluids, vasopressors, and antibiotics based on the patient's progress. Early recognition, aggressive fluid resuscitation, early antibiotics, vasopressor therapy, source control, and continuous monitoring are the cornerstones of septic shock management in ICU.